All right, thanks, Scott. Good afternoon, everybody, and welcome to this live webinar on trauma video review. We're all really excited to be here, and most importantly, really thank you for taking time out of your busy day to learn a little bit about trauma video review with us. So we're all really excited to be here. Honestly, we want this panel to be informative, helpful, and most of all, interactive. So please ask questions liberally using the chat function. We have some dedicated time at the close of the hour to try to address all of your questions. Before we get going, I do want to take a little bit of time to introduce our panelists, and I'm going to let them do that themselves. But I really can't say enough about this group. All of the individuals here today are thought leaders in trauma video review, and I consider them both friends and colleagues, and they're really going to be very helpful in the discussion today that we're going to have about video review. So really quick, my name is Ryan Dumas. I'm an associate professor of surgery at Baylor College of Medicine in Houston. And I've been using trauma video review in my practice for almost a decade. And really, I found it to be transformative for the role of trauma care and performance improvement, specifically in things like research and education as well. And we're going to talk today really about the whole spectrum, but also importantly, hit on some of your questions probably about implementation and how trauma video review might be able to be implemented at your trauma center. So with that, let's introduce our panel. Let's start with Dr. Tracy Zito.
Hi, everybody. I'm Tracy Zito. I'm the Trauma Medical Director at Orlando Health, Orlando Regional Medical Center in Orlando, Florida. Trauma video review is a very near and dear thing to my heart. It's how I trained. It probably the greatest lessons I ever learned in my training were through video review. And it has been my pleasure to be able to bring it to our institution. I think the key word there, as Dr. Dumas said, is it's transformative. And I look forward to talking with y'all.
Awesome. Mrs. Kristen Kryman.
Hi, everyone. My name is Kristen Kryman. I'm the Trauma Program Manager at Penn Presbyterian Medical Center, which is a level 1 trauma center here in Philadelphia. We have been doing trauma video review since 1997. So really, not all me, but a long time here at Penn Medicine. So I've had the privilege to work with many different iterations and many different teams and really watch this whole program and system evolve over time. So thank you so much for having me here today.
And last but not least, Dr. Michael Vella.
Hello, thanks for being here. I'm Mike Vella, a trauma surgeon and trauma medical director at the University of Rochester Medical Center. I've been using video review, I guess, or have experience with video review dating back to 2010 at Vanderbilt when I was a resident, and then in Philadelphia at Penn as a fellow. And then we started our video review program at the University of Rochester about 5 years ago and have used it in all facets of video review, from coaching, research, performance improvement, et cetera. So really looking forward to talking about this and telling about our experiences.
Awesome, fantastic. Let's dive right in here, guys. So let's start with the poll. So please take a second here. We're going to start with a question that's going to kind of set some of the groundwork. What are the biggest challenges with current trauma quality improvement methods that you guys see at your centers? All right, let's take a look at the results. So incomplete or missing data from trauma cases. I think everyone here on that call can agree that this is a huge issue with the EMR, right? And we'll talk a little bit about that in a second. Certainly inaccurate timing documentation and timestamps. So, if we know anything about trauma, is that time is critical, right? And being able to get good data on how long it takes us to do things is something that the EMR is just simply not equipped to do. Difficulty capturing team dynamics and communication. Certainly that's something that's near and dear to all the panel, I know for sure, because we've done a lot of work together looking at some of these things, but you just simply can't talk, or you can't talk well about trauma team performance without having videographic data. Certainly limited ability to identify process improvement opportunities, right? So with video, we can now identify opportunities and areas for improvement. And staff resistance to quality improvement initiatives, right? That makes a lot of sense. And the lack of objective measurement tools, right? So with that, let's talk a little bit about video review and set some of the foundation for why it's so critical and so helpful. So this is what the current trauma quality improvement landscape looks like. This is what we're used to, right? The EHR, simulations, if you have a simulation program, and a lot of centers don't have simulation programs. Certainly trauma registries, right? That's where the bulk of our research data comes from, and our PI data comes through. And honestly, we're left to team recollection. And I know Tracy's post call joining us as this webinar, and if you ask her exactly what happened at 8 p.m. last night when that trauma patient came in, it's really difficult, right? And sometimes it can be really hard, and the further you get out from that resuscitation, the more difficult it can be. So really, we're limited, right? We have incomplete information, inaccurate timestamps, and we rely on memory. And what's missing is a lot of these intangibles. So things like leadership performance. Was there a quarterback that was leading the resuscitation? Team dynamics. How did the nursing team communicate with the MD team? How did the ER docs communicate with the trauma team? All these kinds of things. And certainly technical and non-technical skills, right? So trauma performance is a combination of both technical performance and non-technical performance. And those are just missing in the electronic medical record. And things like tempo, how quickly are things moving, right? Was it controlled chaos or was it just total chaos, right? And time management and processes of care are so critical to identifying in trauma and performance improvement. Because we've looked at this, we've studied this. The EMR is simply inadequate. This is a study that we did at Penn, and Kristen and I were two of the lead authors, and we looked at just a simple question: how often is thoracotomy data time standpoints documented in the electronic medical record? And not surprisingly, these are high anxiety really scenarios and trauma patients, and we miss a lot of the data. As good as our nurses are at documenting what happens, almost all these data points are absent in the electronic medical record, right? And similarly, in the pediatric patients, in severely injured pediatric patients, this group of authors did a validity review study, and they identified 54 errors in 22 patients, and only 10 of those were identified in the electronic medical record. So now, what if you have patients, or what do you have research assistants, right? So I know Penn has a very robust research infrastructure, and they had research assistants watching thoracotomies. So this is prospective data collection, right? So even with a trained prospective researcher that's collecting data as it happens, it's still inaccurate, right? You can imagine, right? Because things happen very quickly, and if something happens and you missed it, you can't zoom in, you can't fast forward, you can't rewind the same way you can with a video. So really, the traditional methods of data collection for trauma are antiquated, especially in a day and age where we have such great availability of videographic data. Now, to be clear, video review in trauma is not that new. It's been going on since the late 1980s. Now it's enjoyed some resurgences lately, largely due to technology advancements and also increasing comfort with videographic technology in our daily lives. But really, in the 1990s, it was done by centers using old TVs, right? And this is a survey that we published a while ago now. And even then, there was a fair amount of centers. This is 30% of respondents were active users in this survey. And we captured over 80% of level 1 trauma centers. And importantly, 20% plan to start in the future. And I will tell you, everybody here on the panel will tell you that number is very much alive. For example, the University of Rochester and Orlando Health, where Tracy and Mike are, they weren't using trauma video review when this survey was published. So it's absolutely a technology that's increasing really month to month. And I think the natural progression has allowed us to implement it more liberally because of technology, right? We expect to be able to track our Amazon package when it's delivered, right? We have our license plate is read at every camera intersection, right? And so the technology has become much, much more secure, HIPAA compliant, cloud-based storage. And all the IT teams I've worked with have tell me that they much prefer cloud-based storage, right? Because it's safer and it's more secure. And so now, instead of having this old VCR with old tapes stacked up in an office, we have HIPAA compliant cloud-based technology that allows us to really manage these videos effectively with minimal concern for medical legal risk. And ultimately, this is what we're looking to do, right? Nobody would play in the Super Bowl, nobody would play in the US Open in a tennis match without having watched a ton of video. How's their swing look? How does the quarterback or how does the defense look on an opposing team? So we are all high-performing teams, And I think that's the absolute takeaway for video reviews, that we have to be able to watch our team perform good in the good and the bad, right? Video review is just as great to highlight awesome team performances as well as opportunities. So, you know, the setup is relatively easy, right? It begins by data capture, right? And that can happen in a number of different ways. It can be cameras mounted on ceilings, mounted on walls, but now we have the ability to integrate technology from multiple data sources. So vitals monitors can be incorporated into video review systems, laryngoscopes for intubation can be incorporated, and that really provides the most robust data and helps you recreate a very granular timeline of trauma resuscitation. And a lot of video review systems now too can be integrated with the EMR to capture some of that electronic medical record data as well. So just this next video is just a simple video of what it might look like and what video review looks like. And you can see here a trauma team performing an assessment of a patient.
Okay. We're just going to roll this to the left, okay?
I have a right radio pulse. Probable.
Now let me get smacked. That's it.
All right, so let's jump right in. I really want to hear from our panelists. So we've broken this up into a few different sections. So we're going to start with clinical applications and use cases. So really, with that in mind, Mike, why don't you start us off a little bit? Tell us a little bit about how your team at Rochester is using it, maybe specifically through the lens of non-technical skills and team performance.
Yeah, a couple things. So the first thing I want to say about the video, you know, it sort of highlights the power of video review because it's de-identified. But I also want to make the point that when you're watching these at your institution, it doesn't have to be de-identified. I mean, it's going to depend on your system and your local policies. But, you know, when we watch ours, like the voices and the people are not sort of de-identified. So I just want to make that point that you can watch it in different sort of capacities. In terms of University of Rochester, so from a performance improvement standpoint, we have a every 6 to 8 week trauma video review conference where we pick resuscitations to watch as a group between surgery, emergency medicine, nursing, et cetera. And I think 2 quick examples of things that have come from that, and this is going to look different at many centers depending on what your schedule is and your resources and things like that. But so I'll give 2 quick examples. So one, we as a program noticed anecdotally that it was taking a long time to get blood into patients who are hypotensive in the trauma bay. And again, this is, picked up by people who are doing these resuscitations in real time. It's not something you're necessarily going to see in the medical record. And so we said, well, as a performance improvement initiative, we're going to review every video of a patient who gets blood in the trauma bay. And there's really a sort of like 3 issues that we identified by watching these videos over the course of a few months. One was the decision-making piece. And I think this will be a common theme, is that one of the things I would say with certainty that you really can't get from an EMR of resuscitation is time to decision, which I think is incredibly important in these things. And so one of the things we realized is that sometimes our residents weren't recognizing the need for blood, and so there was a delay in ordering it. The second thing was, and really the main thing was, is it was really taking our nursing team a long time to set up the rapid infuser device. So sort of an education issue. And so we, from a very granular time point of view, because you can see the blood in the IV tubing, so you know exactly when it's going into the patient. Our median time from blood order to the patient getting blood was like 4 to 5 minutes, which is a long time, right? So we identified recognition of blood, level 1 infuser, the rapid infuser setup, and then blood in the room. We embarrassingly we are getting it now, but have historically not had a blood fridge in the trauma bay, and there were resuscitations where their blood wasn't there in the room, and so you can't give blood if you don't have it. So we took those 3 things. We did very directed resident education about decision for blood. We did, most importantly, multiple sessions with nursing staff about the rapid infuser setup. And then we lobbied our blood bank and said, here's data where the patient needed blood and it wasn't there. And so I'm happy to say that after doing that for 3 to 6 months, we went back and we watched videos for another 3 months, and we took our median time of decision to blood in the tubing from 4 to 5 minutes to 1 to 2, but in reality, most of the time less than a minute. And when we went to the blood bank with our data, they said, yeah, that's kind of hard to argue against, and we got approved for a blood fridge in the emergency department. So that's sort of how one example of how we've used this for PI and education. And again, just very quickly, because I don't want to hog all this, ED thoracotomy, again, you mentioned it's a high, high acuity, low frequency procedure. And one of the things that we really had to emphasize was the decision to make a thoracotomy. Someone comes in with a gunshot wound to the chest, like you don't have to prime the pump. You don't have to put chest tubes in and do CPR. Like if you're going to do a thoracotomy, do it right away. Like what's the decision of thoracotomy? And again, you can't see that in a medical record most of the time. And so really emphasizing with the residents, decision to thoracotomy, decision to blood, I think is key. So that's how we've used it for PI and sort of team dynamics and interaction.
Yeah, I love that, Mike. I especially like that example about the blood fridge. We've heard that use case multiple times. It's just such a good example of like the power of the video. Tracy, I know you guys are really firing all cylinders down in Orlando. Tell us a little bit about your process changes and some of the things you guys have seen clinically. Sure.
So, yeah, we've got the team all jazzed up, but it didn't start that way. It was a journey. And it still is a journey, but I think as we've gone on, people have really realized the utility of this. And we've done a number of things. It started off as a small little conference with just the residents. And out of that started to come a bunch of residents coming to me, asking to review their resuscitations. And just sitting in my office, sometimes one-on-one, going through the resuscitations, or if I see a bad resuscitation, I can call the resident over, and they are very open to sitting down and getting either coached in a positive or negative way, whatever we need to do. That's a big process change. My institution's been a trauma center for, 35 years. And it's, everybody thinks it kind of runs on its own, right? But it doesn't, and we all know that. And I think video review has really brought about the process changes to make everybody realize it doesn't run on its own, and we have to keep policing it. So from that, I want to share a few things, maybe a little less impactful than what Mike shared, but some process changes that we did based on our trauma video review. These are simple things that help flow and actually help us get data quicker that were unrecognized and unrealized until we started reviewing videos. The first is years ago, we went from automatic blood pressure cuffs to manual blood pressure cuffs. And we decided to pilot a couple of weeks of just doing automatic, and we dropped minutes off the primary survey doing that. Our monitors work. Changing from trying to get an axillary temperature on the trauma patients, which is always an interesting, we were 10 minutes, 12 minutes into the resuscitation before we were getting temperatures on some patients. And we switch. It's not the most accurate, but it gives us a great idea to a temporal thermometer, which gives us a temperature right when they arrive. And even in Florida, that's pretty important. And then we had a problem, I'm sure Kristen knows this, problem with documentation of mechanism of injury being accurate. And that was completely, like, we almost got rid of it now that we moved the documentation from non-clinical hands into the nurse's hands, because they know exactly what happened to the patient, and it gets documented appropriately. So our conferences, I have the conference with the resident teams twice a month, which is a small conference. It's really just the current trauma teams. And we review a case from each of the chiefs, each of the 3 chiefs. I was having a lot of trouble reviewing things. We expanded it. So nursing, our ER nurses, trauma nurse leads, now have their own conference. 2 of them have access to the videos. They find videos. They have their own conference to sort of do a performance improvement review on their processes and what they can make better. They also kind of come to our conferences most of the time also. We have a multidisciplinary conference that brings in respiratory therapy and blood bank and all that kind of stuff. So that's infrequent, once a quarter, but it's still getting people used to what we're doing and wanting to come and wanting to see how we're performing. And then it's also being reviewed at emergency medicine conference. They have their didactics, in the morning. So 2 of our ER doctors have access to these, and they're PIing their airway managements and things like that. So lots of uses, and it's there's lots more to do. Yeah.
That's great. That's great. Awesome. Kristen, maybe can you tell us a little bit, maybe things from a nursing perspective? Because I know you guys have done a lot up at Penn with nursing specifically in video review.
Sure. So like Brian said, traditionally this was kind of started as a interprofessional team sport, right? But it was a little bit directed towards the clinical management and physician care. And I think that over time, at least at Penn, we're kind of embracing and expanding some of those initiatives to some nursing focused ones. So, or a multidisciplinary team focused initiatives, expanding on what Tracy and kind of Mike have already articulated. So what we've done is we have a lot of no notice police drop off patients here in Philadelphia, which was is really nuanced to our city and can become really problematic, right? Because there's no prep time, there's no time for team awareness, team preparation. So and they also have no pre-hospital care, so they come in with no vascular access for one. And so we were really having some issues. This was maybe 10 or 15 years ago. And so one of the things that we did was we looked at their vascular access and the different types of vascular access and how long it took and what the success rate was for all those vascular accesses and who can do it, right? Can it be the physician? Can it be a resident? Could be a nurse? And really, we found that, this is the study we did where we found that IOs were really successful, more successful than the other types of vascular access. And between peripheral IVs and IOs really were most expeditious with the time that it took to instill them successfully. So, but the other thing it did was really help empower our nursing team, right? And prove that nurses can be just as successful with insertion as some of the other team members. And so that was just one instance where video review was extremely helpful to help us advocate for, maybe grabbing that IO first and using that IO to get us started and then transition to that central venous catheter as the resuscitation moves on, but then also that nurses can put it in, because a lot of times, the physicians are busy doing some other procedures and maybe the nurse would be the best person at that time to put them in. So that was one of the things we used. And then more recently, again, looking at empowering teams to work together, we also looked at some of the time to blood delivery, and we're actually doing that now. So I don't know if anyone else throughout that's on the conference today has this issue, but we have a lot of turnover here in the city. And, especially, during COVID, after COVID, our ED turnover rates and turnover rates in the hospital were on the, higher side of the national average. And it's kind of settled out since then. But it was really challenging in the moment when our turnover rates were high. And so looking at re-educating and making sure the teams were onboarded and were as efficient as possible was kind of challenging during those times. Plus, for us, our residents rotate like every 2 weeks. So and then we had a military-civilian partnership. So how do you get all these teams onboarded and able to get the experience they need? And so one of the ways you can do that is this multidisciplinary conference, inviting everyone to the table and watching these videos. They kind of learn what a good resuscitation might look like, where opportunities for improvement lie. And then sometimes, if you're struggling with a process improvement, right? So we know that our time to blood delivery could be improved. And not only with the decision for the physician itself, but it's really the time that it takes to get the blood, the whole unit delivered into the patient, right? And so people can be resistant to change. We know that, and change management is hard. And so one of the ways we're trying to leverage some of that change management activity is to use video review. So let the teams watch the time it takes themselves. And then they can come to the conclusion themselves that they might need to do a little bit something extra or add on different adjuncts like a level 1 or Belmont infuser, whatever you have for a rapid infuser, or maybe some other techniques that help to deliver blood more rapidly than just a manual squeeze or a pressure bag. So those are some of the activities that we're really leveraging video review for and have been really successful in the past.
Yeah, I think those are all three of you guys just fantastic examples. Kristen, that the IV axis is near and dear to my heart and Mike's too. So that's something, it's a good example. There's so many technical nuances that we can dissect really through the use of video review. All right, let's keep the discussion going here a little bit. I have another poll question here. Let's give it another minute or two. So for the audience here, just kind of click through here. Here's our question. Which TVR application area would have the most immediate impact on your trauma center? So these are things here that you think, that your team would really benefit from. 30. All right, boom. Let's take a look, guys. All right. So, I like this answer. Yeah. So I think for me, team communication and coordination is just so key. That's the one I clicked. I'm surprised nobody picked leadership. I think leadership's critical too, and it's really interesting when you start watching resuscitations and you can have a resuscitation that is a clear, identifiable leader versus one that does not. Fantastic. All right. So I know, I've been perusing the chat a little bit here too, and already some very good questions, and we'll get to a lot of them here, I think, in this next part. So I want to keep this relatively quick fire here so we can get to everything. Let's talk a little bit first about kind of staff buy-in. I know, Tracy, you kind of alluded to that earlier, that it's been a quote unquote a journey. So tell me a little bit about, you have a relatively new program. What are some of the key things you did to secure staff buy-in before you started this?
So I will compliment you on a paper that you published on sending out a survey, essentially, to try to mitigate fears. But essentially, I had a very resistant culture. I call our institution privatemic. Okay, it is academic. We do a lot of stuff, but we're a private hospital. We don't have a university affiliation. And so this whole concept of video teaching was not necessarily welcome, especially by the non-physician staff. So, it was the big brother is going to be watching and I'm going to get fired, or they're looking for a reason to fire me, et cetera. So we sent out a survey, slightly different, but we sent out a survey asking for pointed issues that they were in fear of or resistant to with regard to trauma video review. We collected those, my trauma educator collected those, and we kind of took the low-hanging fruit, and I issued a reply, and we sent it out to everybody. So the survey went out to everybody, the whole institution, even housekeeping. And I issued a whole reply that went out. And then we started slowly implementing the trauma video review, as you guys know. And we sent out a follow-up survey to that 8 or 9 months into the program. And I almost got no replies. Nobody even felt the need to reply. I haven't had one gripe, one concern, one complaint, literally not one. It's been amazing. And we've done a lot of, hey guys, we need to fix this type stuff.
Yeah, that's
so that's
awesome.
One
that's
way
a really,
we mitigated.
Yeah, that's a really true success story. Kristen, what about you? I know you guys have a deep culture there, but how do you guys manage staff and staff concerns?
We do, but I think that one of the things that I can say is if you do start this process, besides kind of doing what Tracy has done, before every video review conference that we have, so we have it as an educational mission, right? And so we do it at once a month at an educational conference. And we have a PowerPoint that we use, and it has, we use it for any form that we're using it in. So whether it's the nursing trauma video review that we do once a month, or just in the whole team education video review. But we make sure that people understand that about the psychological safety, right? this is an area where, you can trust that this is being used for education, and it's peer review and it's confidential, and kind of what stays in the room, what happens in the room stays in the room, right? So once we leave, it all goes away. We don't talk about it anymore. We don't discuss what so-and-so did. And so it really instilling that psychological safety to feel that you can share opinions and really discuss the case in an open matter is really important. And I think that as the staff attend the meetings over time, they realize that it's truly utilized in that way, and that it won't won't have any negative repercussions when it's used in that space.
Yeah, that's so important. I think everybody on this call I know, and it's often and frequently something we always emphasize when we talk about video review, it just can't be used punitively. The moment you use it to start adjudicating he said, she said issues, I think that's where you lose a bit of the program. Yeah, Tracy.
Yeah, I just wanted to tally on to that, Kristen. It was a big joke when we started trauma video review. I would walk by my residents and they'd be like, "Oh, there's our non-punitive medical director," right? When they were making.
Yeah.
But here we are a year and a half later, and everybody it's not even talked about anymore. So yes,
yeah.
you have to beat that drum.
And I think that's so critical, because this change in culture that you guys haven't used that phrase, but clearly that's what's happening in Orlando Health, and it's happened at Penn and it's happened at Rochester. Like having nurses and residents come up to you, that actually, the lawyers will tell you, and Mike and I have done this paper, that mitigates the risk of medical legal problems at a hospital. Like you're going to have teams that are higher functioning and are going to have better performing trauma resuscitations, which is basically protecting the institution. Mike, tell me a little bit about this kind of leads into a little bit of our next discussion about consent, but tell us about how, I know you started a brand new program, how you guys navigated buy-in, and also how your consent process evolved over the course of your program.
Yeah, we did the same thing, as was mentioned before, as what Tracy did and what you did. And so we studied that as well, and perceptions before and after a new program went up. So we did very similar things. It's meeting with stakeholders. It's alleviating staff concerns. And similar to Tracy, I mean, we've been doing this now for, I guess, 5 years, maybe a little more. I've had only one person ever come up to me with any concern, and really it was about a resuscitation that this individual wasn't even really involved with. It was very early on, and so I think there's an art to how you present these, and I think it's really important that you maintain the integrity of the video review process. And so 2 or 3 times since I've been at Rochester, someone will come up to me. Like we had one where a flight medic came up to me and said, "Hey, the neurosurgery resident was kind of mean to me in the trauma bay. Can we have the video?" And I say no, like we don't use it for that kind of stuff. So I think you have to be really careful to protect it that way, and we've been very cognizant of that. And then from a medical legal standpoint, do you want to get into that now, Ryan, in terms of the
I thought, Mike, really quick, I'm gonna ask you guys, because this came up in the chat already. Really quick, I'll ask all 3 of you guys, how often do you guys meet, and how do you pick videos, and who picks them? Mike, why don't we start with you?
Yeah, it just sort of depends. So the way we do it, so there are some places that watch every trauma resuscitation. I think for our centers, and I know all 4 of us are pretty busy centers, at least for me, that's not practical. So there's many different ways you can do this. What we do is whatever the PI issue du jour is, right? So for us, it was blood transfusion. For someone else, maybe intubations, whatever. One way is to say any resuscitation that meets PI filter X, we're going to watch that for PI purposes. And then, if you get resident requests or staff requests to say, "Hey, there's opportunity. I think there were opportunities in this resuscitation. Can we watch it?" You sort of get those a la carte kind of things that come up. Some places. So that's how we do it at Rochester. Is we'll watch ones for PI. And then for our recurring PI conference, I will usually pick one if I've not heard from anybody else. Since I watch all these, I'll pick 1 or 2 that I think have some learning opportunities, and we'll watch those. But others may do it where they watch, like every Monday they watch resuscitations. There's a million ways you can do this.
Kristen, how do you guys pick it at Penn?
Well, no one's really watching the video reviews on a regular basis, so other than some research or some things. So our PI team and our registry team help. So we have a physician that's identified as the lead. Anyone can bring, a request to review a video, like if there's a really difficult case. But we try to rotate themes around. So, we might watch a blunt, we might watch a penetrating, we might watch something like if we are seeing some recurrent performance improvement issues around, airway positioning or different things like that. That's kind of how we choose to triage our cases at the time. And then we want to make sure that there's an array, right? We don't want to have all really awful or, like a lot that have opportunities for improvement. We want to show some really great cases too, because that's a wonderful learning opportunity to see how something is done really well so that you can, aspire to having a resuscitation like that.
Tracy, how do you guys pick cases?
So that was also a journey, right? You start off being completely overwhelmed, not knowing what to look at, how to look at it.
It's a lot of data.
Probably the best, I had a great suggestion by some of you guys to have the PI program identify, high ISS cases or what have you. And out of those, we got some really good resuscitations and some ones that have really good opportunities for improvement. We put a TVR suggestion box in the trauma bay. And so literally you can pull a napkin off the sink, put a sticker on it, write TVR and stick it in the box. And my educator will grab those. She grabs them once a week. But outside of that, that formal process, today I got a text message from one of the chief residents. Can we please review this video? I've really had opportunities for improvement. So a lot of them, I get the one-offs like Mike was talking about. I think we're moving to mature into the PI issue du jour, as you mentioned, because that's kind of where we're going with it.
Yeah, I just got an email from one of our nurse leaders like 2 days ago, same thing, said, hey, I think there was some opportunity here. These are always like 99, aside from those random, hey, so-and-so was mean to me, can we watch the video, which are very infrequent. Most of these are, they're not people looking to get somebody or picking on a specific individual. It's really, hey, I think there were some team opportunities here. People wanting to get better. Again, it goes with what you said, Ryan, with the culture, change, is that really it changes. Even though video review is one aspect of a robust performance improvement program, it really is powerful and really can change the culture where people want to get better or watch themselves learn.
All right. It's absolutely fantastic. So really, we have 5 minutes because I want to leave. There's a ton of questions, so I want to leave a lot of time for questions. So we have 5 minutes to tackle something that's come up a little bit in the questions already, and that's the consent process. So let me be very clear for the entire group. HIPAA protects the use of videographic information. All right. So that is well documented. It's very clear in HIPAA. Basically, if it's used for internal purposes, for QI and performance improvement, is protected. JCO, which is another entity, doesn't actually govern the physical data. They just want to see that you have policies in place that protect the program, or in this case, that you have a policy for how do you handle your videos. So most systems, because this has come up a few times already, most systems auto-delete videos, right? Because it's cloud-based, it just falls off after 30 days. And most systems will allow you just to tweak that if you want to keep them longer or less duration. But the key is having a policy in which the videos delete quite promptly, and then that makes them undiscoverable. And it is protected, again, it is protected in HIPAA. So that being said, I'll just start with saying how we've done it in the past. But in both programs that I've worked in, we consent patients under the general admission for treatment. It's literally the first line of the consent. It says all or parts of your care may be videographed or photographed, and that they will only be used internally for QI purposes. So I know not every center is the same. So really quick, Mike, how do you guys do it at Rochester?
We no longer require consent for video review.
And that changed, right?
Yeah, it changed. So JCO used to, I don't know what the official term is, I guess require or look for consent for audiovisual, even for PI purposes, but they changed their verbiage in the most recent requirements to something on the order of they, suggested or can be considered, but it's not sort of a joint commission mandate. Was our legal team's interpretation of everything, and so we no longer require consent, and it was quite prohibitive, really, from a PI standpoint, to do that. But real quick comment to what you said, Ryan. You're right. I mean, this is audiovisual equipment data is as protected as any PI issue is protected. But it's really important that if you use video review for PI, it has to be part of your PI plan. It has to be documented.
That's a great point.
As part of your performance improvement plan as an institution, or you may not have the same protections afforded to it. So it's very clear in our trauma PI program that video review is part of our tertiary review process for trauma patients.
Kristen, how do you guys consent patients for video review at Penn?
Yeah, I think my biggest advice would be, make sure you're partnering with your OGC, your Office of General Counsel, right? Because every state law is different. And so there's nuances by, whatever state you're practicing in. So for ours, we have it in our hospital general consent, and they have to opt out. So it says that, that it's not part of the EMR, that we erase these after it's being reviewed, that they can opt out or decline collection, and that we are not providing them any compensation for using this for educational purposes, and that it can be video, audio, or digital recordings of images. So that's some of the language that we have in our hospital consent.
Tracy?
Ours is very similar to yours, Ryan. It's the first or second line in our admission consent form, and so every patient signs it, or their loved one, whatever.
Yeah, it's really cool, honestly, to see that evolution. I think Mike's probably the best example where there was a previous legal team that was maybe a little hesitant, and this speaks to some of the questions in the chat already, but then basically they did away with their consent process because it was inhibiting the program. And similarly, at a previous institution that I was at, they also had an opt-out, Kristen, but then they were finding that none of the patients were opting out, so they removed it from their consent. So I think, it's interesting to see as people, and it speaks to one of the comments I made earlier, that we're simply just used to this kind of videographic data. And I think a lot of times our patients even kind of expect it in the sense that, why wouldn't you want your team to be performing at the best if it's one of your loved ones, or heaven forbid you, so I think it's really interesting to see that evolution and consent process over time.
Brian, if I may, the one thing I might say is that, when you think about this, it's not just what we're talking about today with trauma video review, but, you have security cameras all over your hospital. And so they're not just opting in or out for trauma video review. It's like the whole hospital. And so, we have signs posted that you may be under video surveillance, but, think about that when you're advocating for this, if you're advocating this for the first time at your center, is that, you've got a different focus as well, like, security footage in addition to this separate process.
Yeah, and I would say when we used to the last comment, when we used to require consent for this, having watched a lot of ED thoracotomies where we all know the mortality is extremely high. I mean, I probably have called at least 30 families of people who have died, which is a tough conversation, but a necessary conversation if you want to use these for, we were doing a research study at the time. And I will tell you that every single family member I called was totally on board. They understood they understood that it makes the team better, and if they could help somebody in the future, they were on board. So that's just sort of one anecdote, but I think the power of it.
Yeah, it's a powerful point.
From a patient standpoint.
All right, guys. Well, this is the last poll question, and then I think the timing will be great. We have almost 10 questions to get to. Please, put your questions here as they come up. But while we're waiting here, what is your current status with video review technology? So this is interesting, right? So I may let this one percolate for a minute or two longer because I kind of want to see where the cookie crumbles here. And then while you guys are answering this question, let's kind of start. I'm going to scroll up here to our Q&A here and kind of go through some of these and talk a little bit about some of these questions. All right, I like this first one. I'll tackle this one just because that's something that's been near and dear to my heart. So I think it was, I apologize, I don't have the name of the individual, but somebody asked about AI. And man, I love, you can't really read anything this day and age without having AI interwoven into some kind of conversation. So the question is, are you using AI to help with data identification or analysis? Yeah, that's an excellent question. So I like to say there's no flaws with video review, but there are, and the Achilles heel is that's a lot of data. And it takes a lot of time. You've heard a lot of the panelists say, annotating videos or reviewing videos, and it takes time. And so there's undoubtedly, yes, the short answer is yes. We have used AI really only in a research capacity, but there is a world in the not so distant future in which, a video review program will hopefully be able to pre-screen videos basically for you based on a trained model, which detects patient arrival, patient EMS timeout, chest x-ray, those kinds of things. And that allows you to then find those more high yield videos and get more out of your program. And then the more obvious applications for AI, which you guys have seen today in the video, is de-identification, right? So there's pretty robust platforms now that will fully de-identify the video, and you actually scale it up or down, right? So I know Tracy uses a totally identifiable system, which is obviously, I think, most of our biases here because you can see everything. But also, there's some centers that are a little bit more protective of staff and patients, which is totally reasonable. And so you can have a fully de-identified system too. So those are things that are usually done with AI. All right, looks like we have our answers submitted. Let's take a look. Great, it was pretty evenly split here. We have about 20% of the audience that's already using video review. Another quarter looking to optimize. So that's great. So nearly half the audience is already using some kind of program. Fantastic. And I like so it'd be interesting to hear a little bit from the last cohort. They're unsure about feasibility at our center. All right, so let's see. Question-wise, guys, let's get here. Let's. Yeah, would you be willing to share what company or software you're using? Mike, what are you guys using? Do you know what you're using?
We use a Vigilon.
What's that setup like?
We have sort of two fisheye cameras and a microphone. We really only use the one camera at the head of the bed. We find the fisheye camera at the foot of the bed is not that helpful. And we like the system. We're looking to look at other like the sort of trauma black box technology for our new trauma bays, which will be done in 2027. So we're actively planning that now. But we do like what we're using now.
Kristen, I think Kristen, you and Tracy are both using the same platform, right? So
yeah, we transitioned. Our old platform was end of life and wasn't supporting it anymore. So we just transitioned to Surgical Safety Technologies, which is a trauma black box and the OR black box. So I'm loving it.
So you guys have them both in your trauma bays and your operating room?
Well, the health system has it in the operating room and the trauma bays. So yeah.
Tracy?
Yeah, we're using the trauma black box. We have, 2 cameras, and I'll be honest, Mike, I swap between them, but what I have found is you got to make sure the obstacles are out of the way, right? Like we have OR lights in our trauma bays, and it is not uncommon for somebody to put the OR light in front of the camera.
I think people do that on purpose.
Yeah, exactly.
Well, that's right. Like I think it depends on. I guess to clarify, like with the fisheye style camera, it doesn't provide the view you're talking about. Like that's the problem with is to have 2 of those. If you have 2 of a different type of camera that gives you a different view, that would be helpful. So there's a lot that goes into it that we didn't really realize at first. That being one of them, the type of sort of camera matters.
Yeah.
I guess it's intuitive, but it's hard to know that going into it, what style you're going to need.
Yeah, that's great. That's really great. So we kind of covered question number 4 already. Do you require consent prior to video recording resuscitations? We've updated our general consent forms, but still require patient family sign before viewing. We see some losses and opportunity related to this. So that's very similar to Mike's program. So hopefully we've kind of answered that question. What I would encourage you guys to do, and you're welcome to reach out to the panelists, and I'm sure they'd be happy to share their policies. If you're looking to start a program or having difficulties with medical, legal, or administration, there are ample centers now that have policies that I'm happy to share with. I think probably at least once or twice a month, I send them out to co-workers. Yeah, I know Kristen sent me hers recently. Tracy has one. Mike has one. And so don't reinvent the wheel. Like, ask other centers, can I see your policy? And you know, that goes a long way. So I'm at a new system here, and I literally had this conversation probably about a month ago. I sent my legal team 5 different policies with video review, and they basically said, like, okay, this looks good. I think we can do this. Because, you know, I think having clear, well-written policies from other institutions make it seem much more attainable. Any other comments about that, guys? Okay. Here, Tracy, how do you choose your cases for multidisciplinary review, including resuscitated thoracotomy, blood bank, those kinds of cases? Do you choose well-run, or do you choose only opportunities for improvement? And how do you guys kind of figure that out?
So both. I think we all realize the older we get, it's sometimes even more important to show the well-run.
Yeah.
And it also, it jazzes people up when they see a very well-organized resuscitation. So between Krista, she's my educator, and we really try to come up with a couple. I also, it's not just the type of resuscitation. Like Kristen said, mix it, you know, penetrating and blunt. But I try very hard to make sure that it's pertinent to the people that are in the room. So I will choose a case for each of the chief residents, each of the 3 chief residents, to review during the month that they're on trauma, so that they're seeing their reviews, their videos. Do you see what I mean?
Yeah, that's awesome.
And I found that that's better. So that's part of how I narrow the focus down is, okay, I need to pick a resuscitation for Justin, you know?
Yeah.
Kind of thing.
This question we haven't directly answered, but I can take a stab at it just because I've been at programs that do both. How does the equipment work with turning on and off? Is there a person who needs to start the cameras? So I'll let the panelists quickly answer how they do it, but I have been at a stop-start program, and I'll tell you, you lose data. So we actually transitioned to a continuously recording program. And actually one of the sticking points initially was because it was too much bandwidth for the video review program at the time. But since then, cloud storage and has gotten so much better that we were able to continuously record. So strongly recommend continuously recording programs. Tracy, you guys continuous recording or stop start?
We started with the stop start. It didn't work. And I think I may be wrong, but I do think that AI plays a role in how when you do the continuous recording, I think AI plays a role in starting or honing in on the video, right?
Yep.
So we are infinitely happier with the continuous recording.
Kristen, what are you guys doing now?
We've always had continuous recording because we tried to switch and it doesn't work. I mean, the cases you want are the ones that the team can't stop to press the button. So,
exactly.
But yeah,
those are the high going, high stakes ones.
Exactly.
Mike, what are you guys doing?
We have a start stop, and I'll tell you that I think to pat ourselves in the back, I think we did a really good job with education. So we haven't missed the video in a long time. However, we just started watching burns, which we've not done as part of a burn TVR study we're doing, and so it's like a new thing, and we've missed every single one of them. Sending out. So it is. I agree. The continuous is better. Like, we've done a good job because we really educated people and made like signs on the wall, like made it glaringly obvious to hit the buttons. But I think continuous is better.
Next question we've kind of answered, but I think it's worth revisiting. Stephen, not to call you out, but I think it's a fantastic program that everybody universally feels. Our trauma program has taken multiple runs at getting TVR program off the ground, but our enterprise legal experts will not engage in conversation. They only say no based on confidentiality concerns, and advise on how to get them on board. Really, just leverage these kinds of discussions, these kinds of panels. Send them the link to this live webinar after. Send them some data. Like Mike and I have spent a while making this a bit of a passion project, and we recently published something in the journal Trauma, which looked at legal cases of video review in the trauma literature. And basically, it's almost there are 2, both of which were dismissed. And so the legal and the advice from the lawyers was, again, that change in culture, the benefit that you have far, far, far outweighs the small, it's never going to be zero, your medical legal risk, but it's far outweighed, especially if you have a good policy to delete videos. This one's worth mentioning it because you guys may have experienced some of these. For any interpersonal disputes or inappropriate behavior during a video review, what process do you follow while preserving the integrity of the video review process? Tracy or Kristen, has that come up in your shops?
I can speak. Yeah. I would favor to be careful about what you're choosing. You know, unless there's a specific point that you want to bring out at your video review, that might not be something that you want to choose to discuss in that form. It might, you know, if it's not beneficial for the whole team, then it might not be beneficial.
Tracy?
So I was going to say almost exactly the same thing. I don't pick videos to review that have behavioral issues that anyone would want to address. I specifically try to stay away from them unless it's impeding. No, you know what? I think I would just say I can't even remember one that I ever reviewed that had a behavioral problem. It doesn't belong there. You know, it just doesn't.
Yeah. This has been fantastic. We're at the top of the hour. I think we have maybe 30 more seconds. I do want to answer this because I think it's really important. Sustainable funding, and that kind of loops into another question where somebody asked if you have dedicated PI resources. So I think the three of you would be really helpful to answer. Do you guys have dedicated resources or any kind of sustainable funding? How do you guys fund these programs?
We just used, we advocated for capital, and it was a hard sell, but we did it. And all I can tell you is that, you know, if they don't want to fund it, start small, because anything is a win, right?
That's a great advice. You can always scale up.
Yeah, exactly.
Mike, sustainable funding?
Yeah, we got a grant through the emergency department helped us get a grant for this, for the initial setup. Now, as we transition, the benefit of taking advantage of having a new trauma bay, and like this is a drop in the bucket compared to a multi-billion-dollar expansion, and so that's kind of nice to get new cameras for the new bays. But the ongoing, you know, if you have a system with ongoing subscription costs, can be a little more challenging. So you just have to have buy-in from your institution. There is grant funding available in some cases, so I encourage people to look for that. Tracy?
Yeah, so our cameras got put in through a grant from our foundation when we renovated the trauma bays, and the organization is sustaining it.
Yeah, and I think that's key, right? I think as Kristen says, it's scalable. And once the organization sees the utility and the value, I've almost universally, I've seen programs expand and scale and not like shutter. All right, we're a minute over. This has been absolutely fantastic. Thank you, Beckers, for hosting. Guys, I can't thank you enough for your time. Hopefully this has been a wonderful, helpful discussion for everybody. So we appreciate you taking the time. Thanks for logging on.